For joining us for the Substance and Medication Abuse Misuse Among Older Adults webinar. The facilitator today is Linda Shumaker, and I will turn the screen over to her now. Okay, Linda, if you'll click on that screen, on that message you have, there we go.
But I lost my upper right little panel.
Oh, just go to the your icons along the very bottom of your screen if you have icons there for your different programs. And
no, because it's taking up my whole screen.
Yeah, just go to, do the Alt tab, and you'll see, you can click through whatever programs are open. Yeah, just click on the, you can click on the blue flower, and that will get your panel back up.
Oh, no, it didn't. Okay, Alt tab.
Yeah, and click on the blue flower.
I'm not seeing it. I'm not kidding.
See,
when I hold it,
yeah,
okay, I got it.
Yeah, click on the blue flower. There you go.
Okay, now, thank you very much. Okay, good afternoon, everyone. And I am going to be speaking about substance abuse and medication abuse and misuse in older adults. And just to give you some background, this presentation was something that was done through the Penn State Geriatric Education Center in 2008. And I just want to recognize CarolHancockGold, who is a Senior Research Associate at Penn State, and E.Hanna, who at the time was the Executive Director of the Bucks County Drug&Alcohol Commission. The three of us worked on this presentation together, and I've updated it several times, but I really would like to credit them with participating in this. This presentation is actually extremely important because the population growth we're seeing in older adults and the substance abuse and medication misuse issues that we're going to be seeing in the coming years. And I think that's why this presentation is requested so often, because we really are, and currently we are seeing some increases across the board. I am a registered nurse by trade, and I actually still have a clinical practice. I teach and I consult. So you'll hear me just give you some examples from my own practice and my own concerns that I've seen over the years. What we're going to talk about today is everything that you see listed on that next slide. We're going to talk about prescription medications, over-the-counter medications, alcohol, illicit drugs, and any combination of there are. It's estimated that the number of older adults in need of substance abuse treatment will increase from 1.7 million in 2001 to 4.4 million in 2020, and we're actually seeing that increase go up more than was projected initially. It is due to a 50% increase in the number of older adults and a 70% increase in the rate of treatment need due to a higher abuse rate among older adults. And that is due to the boomer population, which I'll talk about in a little bit, the specific needs of those. Currently, the over 50 group makes up about 10% in substance abuse treatment, approximately 1.8 million older adults, but that's predominantly for alcohol, which is, you would think, from that generation. Of those in treatment, as I said, alcohol is predominantly the drug of choice, but it's the 50 to 64-year-olds that have more extensive substance abuse treatment histories, and we'll talk about some of those issues that boomers have, and that's where the problem is going to be, and that's where we're seeing the biggest growth right now. The majority of problems in the current older adults are related to prescription medications alone, alcohol in combination with prescription medications, over-the-counter, or alcohol alone. Which is what we would expect. People in sleeping pills, older adults in sleeping pills. In my clinic, I saw an older adult last week who claims that he has one martini every night, and his daughter actually is 87 years old. His daughter actually says it's more like 3 or 4. So, plus his prescription medication and some psychotropic medications that he's currently on. So what we're seeing is an increase in that population, in those issues as well. Older adults are increasingly, numbers are also addicted to illicit drugs. It has gone up rapidly in the past few years. It's actually doubled to 4.1% of the population. And according to the National Survey on Drug Use and Health, which simply defines illicit drugs as marijuana, hashish, cocaine, inhalants, hallucinogens, heroin, or the big one that we see with this generation of older adults, prescription-type drugs used non-medically, which means they're being used for the feeling that they cause. Non-medical use is used for prescription-type pain relievers, so it can be things like Oxycontin, tranquilizers, things like Ambien or Ativan or Valium, stimulants and sedatives that were not prescribed for the respondents by a physician, or, as I said before, being used for the experience or the feeling that they cause. And they include the opioid analgesics, even simple things like Darvon, but certainly like Oxycontin, which we're seeing a huge increase in, CNS stimulants like Ritalin, Cylert, minor tranquilizers such as Valium, Ativan, sedative hypnotics, Seconal, Amibarbital, Ambien, things like those, benzodiazepines across the board. Current illicit drug use by this generation of older adults is the lowest rate, but the concern is we baby boomers, and I am part of that generation, it's approximately half the baby boomers have tried illicit drugs, and what we know is that birth cohorts that experience high rates of illicit drug use in earlier years show higher rates of use as they age as compared to older cohorts. So literally, people sort of go back to what was accepted, back to Woodstock. I actually saw online a few months ago a panel discussion from the Hanley Center in Florida, which is the place for older adult substance abuse. And they were talking about why the boomer generation seems to use illicit drugs more so. And the discussion was rather enlightening, and one of the things that they emphasized is the fact back when we were kids, illicit drug use was almost normalized. Between marijuana use, between hashish and things like that, it was almost an accepted way of life. So as they get older, that the use of those illicit drugs is actually increasing. And one of the interesting things for me, one of the articles that came across my desk a few months ago is that women, they didn't think women would be using marijuana and hashish as quickly as they are, but the increase in marijuana use among women is going up faster than they thought. So once again, those for the boomer generation, those types of illicit drugs actually were almost normalized when we were growing up. And this next slide is from 2009. It's from the National Survey on Drug Use and Health. Women aged 65 and older report non-medical use of prescription drugs, so things like Oxycontin and using things like that, and that's where, as I said before, the reports of marijuana are increasing. Men aged 65 and older actually report equally marijuana use as well as non-medical use of prescription drugs. But women, once again, it is increasing much more than they thought. Of concern is this increasing rate of substance abuse in the baby boomer generation, and that goes to non-medical use of prescription drugs. Americans are 4.6% of the world's population. However, we consume 80% of the world's opioid supply. So we're supporting Afghanistan in more than one way with the use of opioids or the abuse of opioids. They're seeing a lot more unintentional death rates from overdoses of opioids in this country, and that's something that I just read late last week. So that people are taking it, not realizing that they're overdosing on it, and they're actually dying from it. And these are not ruled suicides. These are unintentional deaths. The highest percentage of deaths from overdoses in 2004 to 2005 are the 45 to 54 age group, and that's actually what they were saying last week as well. It's the same age group. So that is rapidly increasing over the past few years. Therapeutic opioid use has increased substantially, yet it's only demonstrated for short-term acute pain. There are multiple adverse consequences. There's, believe it or not, there's hormonal and immune system effects. There's, of course, abuse and addiction tolerance and hyperalgesia. No, I'm not going to be able to say it. analgesia, which is an increased pain sensitivity. So it's almost like they're become even more sensitive to pain, which is one of the problems with the addiction. Long-term use has shown to increase the overall cost of health care, which is one of the things I am so interested in. The disability rates, the rates of surgery, and of course, late opioid use. With medication, and I've sort of broken them down for you, medication misuse and abuse. Adults 65 and older consume, and I think we all know this, more prescription medications and over-the-counter medications than any other age group. They are 13% of the population, but they consume 25 to 30% of medications. That's one of the fastest growing health concerns across the board. And you'll see why when I go through some of these slides, and you'll see why health literacy and healthcare costs all trickle into this huge, huge complicating picture. Once again, 25 to 30% of all medications, 70% of all over-the-counter medications. And I want you to think about the things that are now over-the-counter. Benadryl is over-the-counter. Benadryl is the thing that's in Tylenol PM and Excedrin PM. So, and believe it or not, 25 milligrams of Benadryl are in those medications. So if you have an older adult taking 2 Tylenol PM every night, they're actually getting 50 milligrams of Benadryl. And some older people who are having cognitive issues, that actually can tip them over into an acute delirium, make them look extremely confused, have hallucinations and delusions and things like that. So even though we always say over-the-counter medications are somewhat benign, they actually not necessarily are to an older adult. The average adult over 65 uses 11 different prescriptions in 1 year, and I think if you look at some of the medication lists, if you're a practitioner, it just impresses me greatly when I see clients coming in or patients coming into our clinic that are on 19 different medications. And they may be 86 or 87 years old and having cognitive difficulties or depression, and how do you sort of weed out what's going on with those medications. 1 out of 4 prescription medications taken by older adults is psychoactive. And you'll hear that, you'll see that again and again in the literature, how it is psychoactive. I also just want to mention now that Medicare will pay for older individuals to go see their they'll reimburse for older individuals to go see their primary care physicians. It's called a well visit. And the primary care physician literally can sit down and review all the medications that they're on. And my mother actually walked into her family doctor a few years ago and said, I want to get rid of some of these things. I don't think taking all this is good for me. And I really applaud her efforts with that. It's very, very important to have medications cut back to as few as possible. When I was in school, I was actually taught that an older adult shouldn't be on any more than 5 different medications. So it's really sort of disheartening when you see the amount of medications that older people are on. The other big concern is 50% of prescribed medications are not taken according to directions. There was a study in the New York Times, I believe it was last spring, or maybe it was even the spring before, where they targeted Hispanic and African American population in New York City, and they found that 50% of them did not take their blood pressure medication or their diabetes medication. And the question, of course, is why not? And twofold, because when you think about the issues of not taking your antihypertensive and your diabetes medication, what's that going to do to healthcare costs because of issues of stroke and issues of increased health problems due to those 2 very severe diseases. The respondents, first of all, could not afford the medications, nor did they feel that the medications, they didn't feel they really had a problem because they didn't feel sick from their diabetes or sick from their blood pressure, so they didn't think it was that important. So it's things like that I see as problems with health literacy and where we're failing and to educate individuals the need of these medications and actually the long-term effects of not taking the medications according to directions. And just as an aside, African Americans and the Hispanic population are at risk, higher risk for dementia, 1.5% and 2% higher than white Americans at risk for dementia. So, and it's because of the risk of the vascular history with the hypertensive problems and the diabetes problems. So obviously the healthcare system is failing in educating individuals. Older adults experience 2 or 3 times many adverse reactions as do younger adults. 1/2 of the individuals who are hospitalized for adverse drug reactions are over age 65, and they may not even be labeled as that, so I think that number could actually be higher. And of course, special concern is prescription medications and alcohol. And I'm just going to share a little vignette with my family from about 3 years ago. My mother has severe degenerative disc disease in her back. Her back literally is shaped like an S right now. But at the time, she was living at home and functioning fairly well, but she was staying in bed a lot. And I, of course, was trying to figure out how much OxyContin she was taking because that's what the pain management people prescribed for her. So my dad was getting up in the morning and counting it, and we're trying to sort of do it discreetly because my mother did not want us involved in her care because she kept saying, I can take care of it myself. I've been taking care of it for a long time. My other concern was my mother always had a light beer every night before she went to bed, and I was assuming it was still only one. And my father, like he goes to bed relatively early, so he wasn't sure. So we were trying to monitor that. And finally, at one point, about 3 months into this, my mother actually got physically sick, and we had to intervene with her primary care physician, who knows me well. And I called him, and he said, Linda, what's going on? He called me back right away and said, what's going on? And I said, well, I don't know. We don't know how much OxyContin she's taking. It looks like she's taking it as prescribed, but I'm concerned about that. She's having a light beer every night. She's got thyroid problems. Is she anemic? All of this. So it's very difficult, just to stress with this, it's very difficult with older adults to weed these things out. Fortunately for us, my mother was undertaking her OxyContin, which is why she was in bed all day, because she couldn't stand the pain. But we had to sort of get her back referred to pain management to get on the proper dosage and to get a TENS unit to sort of help with that. So I can tell you personally, it really hits close to home, and being that I'm in the business that I literally look for this stuff, and I think we need to really share this experience so that people understand the importance of it, because it affects older adults' quality of life. It really does affect their quality of life. And big part of the concern is that age-related changes, and those of you who are not nurses or physicians who don't know this, there are many age-related changes which are normal. A decrease in lean body fat as we get older is normal. It's actually displaced differently. Fat increases, it goes to different areas. Total body water decreases, so absorption is different. There is a decrease in the stomach's ability to metabolize the alcohol, so people actually can get drunk much quicker on a smaller amount. There's kidney changes in your kidneys, so that medications and alcohol are not excreted as quickly, the same way with liver functions, and brain-related changes as well really cause problems for older adults. Now, of concern is the fact that older adults don't know that they're having trouble with medications and alcohol. They may be suffering and not know it. The other concern is, once again, that older adults are likely to be prescribed long-term medications as long as multiple medications. The large percentage of individuals who use not only over-the-counter, but herbs, dietary supplements, along with their prescription medications. I had a gentleman I ran the outpatient geri psych clinic at Hershey Medical Center through Penn State a number of years ago, and we had a gentleman who we were treating for a major depression. He was about an 85-year-old, could not get him stabilized on any of the normal antidepressants, and he was going to Germany, and when he went to Germany to see his daughter, he actually picked up St. John's wort. And it worked for him. It worked great. He brought a few months' supply back from Germany when he came home, and after that few months' supply was gone, he actually just went and bought it at the local pharmacy, and of course it was not the same strength. It wasn't cut the strength because herbal medications are not regulated in this country. And he actually got depressed again. So he had to get his daughter to bring him more of the St. John's wort from Germany back because it worked for him. We're not sure how or why, but it actually worked for him. So there are differences, and you need to look. You think that herbs are benign, but they may not be. And once again, we don't know what they're cut with. So it can really lead to problems, especially for older adults. There also is the risk for prescription drug abuse, where older people are taking medications unintentionally. They take them and they think they need them for sleep, or they think they need them, and they got past their husband's death taking a couple Ativan a day, and it's continued, and it's actually increased, and they actually become accidental addicts. Overuse, underuse, or irregular use of prescription medications and over-the-counter drugs are forms of drug misuse, okay? Even underuse. Okay? Older people experience much more adverse health consequences with these medications simply because there are high rates of comorbid illnesses, the potential for drug interactions, whether it be an over-the-counter medication with a prescribed medication, and the changes in drug metabolism that accompany aging. And once again, that is normal age-related change. It's not a disease state, which results in the drug activity staying in your body longer. I've had individuals come into my clinic. I talked before about Benadryl, but we had an 82-year-old woman come into the clinic who was taking 4 Tylenol PM every night to sleep. And of course, being the good clinicians that we are, we tried to wean her off. And after 3 months, she finally fired us. She said, you know what, they've worked for me. They always work for me. I don't sleep when I don't take them. I'm not coming back here. So extremely important for us to know about the medicines, caution people, and to follow people. And what we did was, of course, notify her family doctor. She wasn't having any cognitive problems. What her big complaint was sleep. So, and those medications were working fine for her, but somebody else, I know if I would take 50 milligrams of Benadryl, I would have trouble staying awake the next day and probably for several days. A lot of times older people will have hangovers with those with sleeper medications. In the geriatric psych clinic that I currently run, we do not recommend any sleeping pills or sedative hypnotics for older adults, simply because they can have such adverse reactions. And that's what the concerns are. Those are anxiety, depression, insomnia, and other mood disorders. And once again, 25% of older adults use psychotherapeutic drugs, use over-the-counter and herbal supplements. So we really need to be aware of what people are taking. I tell them to bring in all their medications, all their over-the-counter in a brown bag. I do the brown bag approach, and they always say, well, I don't. I said, just put it in the bag so we can see what you're taking. We had a gentleman come into the clinic one time who was seeing a chiropractor who was prescribing medication. And for the life of us, we Googled, we did everything. We could not figure out what medications he was on because they were mixed privately by this chiropractor. So you have all these things that sort of factor in. And this gentleman was having cognitive issues, and we weren't sure. They weren't looking like a dementia, but we weren't sure what was going on with him. Risk factors for medication misuse, once again, are taking extra doses, missing doses, not following instructions, taking the wrong medications, using medications that have expired, not knowing about the side effects of medication, sharing or borrowing medications. My parents shared, they're antihypertensive, they were both taking the same thing, and my mother ran out, so she started using my dad. And then they wouldn't fill his. And people don't think about that. So people need to know that they should not be borrowing or sharing medications. Mixing medications or drinking alcohol while taking medications, going to multiple physicians to get more of the same, or going to multiple physicians who are unaware of the medication regime. And once again, this is health literacy, and we'll talk a little bit more about that later on, but it stresses the need for physicians to be exchanging information across the board. And the silos of care that happen in our healthcare system are one of the biggest problems. I can tell you in my clinic, I fax progress notes literally out to primary care sites. Whatever their family doctor is, cardiologist, whatever, I fax them to the doctor so they can see what we've done with medications, and then they can make their decisions from there. It's extremely important. The risk of drug abuse among older persons increases for many reasons. There's inappropriate prescribing, and believe it or not, especially for women. There's a failure to tell doctors about over-the-counter herbs and vitamins. Individuals have memory problems, and they may forget what they take. They may have written it down in their wallet, but they don't bring it with them, or it's illegible. They may have trouble taking their medications. One of the big issues for me is the small print packaging on labels and prescriptions. And you can see if the pharmacy will do a larger print. Many of them can do larger prints on packaging for you. Health literacy issues, like not understanding the physician's instruction and what that means. Things like not understanding what hypertension means and not knowing the importance of taking that medication, not knowing that affects your kidneys and your vision, your diabetes, even though you may not feel sick with it. But actually, if your blood sugar stays high for a long period of time, it does put you at risk for stroke and kidney problems and things like that, that we're really not educating individuals well enough about the health problems that they have. Missing or misunderstanding instructions through vision, hearing, or language barriers. One of our biggest concerns in our clinic is we have no one who speaks Spanish, and we're getting a fair number of referrals into our clinic who are only Spanish speaking. One of the funniest stories that happened to me just a few months ago is I went to meet my father at my dad has bilateral hearing aids and poor vision, and he was seeing the surgeon for his ophthalmologist, and I got to the appointment late. And I went wandering back. They said, "Oh, Lindy, he's back here." And I went into the office where he was sitting, and the woman was talking to him about his pending surgery. And I said to her, "I'm sorry, but my father's not having surgery. He's here to see the doctor for this." And she said, "No, he's having surgery." And I said, "No, my dad isn't having surgery. He had surgery 6 months ago, and something happened, so that's why this is following up." And she said, "No, he's having surgery." And I said, "No, he's not having surgery." And finally, she looked at the chart, she looked at him and said, "Are you so-and-so?" And he said, "No." And my dad, thank heavens, just laughed and said, "I'm so glad you came in when you did." But we need to make sure that people hear well and understand well. And even if they shake your head or they respond, you need to double check when you're starting to talk to people or assess people. Extremely important. With medicines and alcohol interactions, you need to remember that even social drinking can be a problem for somebody taking medications regularly. It's one of the concerns from the gentleman that I talked about initially, that he claimed he was only having one martini every night, and his daughter said it's more like 3, because of the medications that he was on and the medications most older adults are on. Some examples of dangerous drug-drug interactions are Tylenol can cause liver damage, taking 3 or more drinks a day. Aspirin and arthritis medications and drinking alcohol can increase the risk of a bleed. Alcohol can worsen central nervous system depression in people taking antidepressants. High doses of sedatives mixed with alcohol can be lethal. They're drinking alcohol and medications for hypertension, for high blood pressure, diabetes, ulcers, gout, and heart failure can make those conditions worse. Cold and allergy medications, and mainly, those are over the counter, contain antihistamines that make people feel drowsy, and drinking can compound that and impair coordination, so you have this increased risk of gait disturbance and falls. So, of course, the ways to avoid medication misuse is addressing health literacy, which was actually a big push by the AMA, I think in 2008 and 2009, and you can go on the American Medical Society's or American Medical Association's website and find many, many things on health literacy. And HRSA, which is the Health Resources Services Administration, actually has I believe it's a 5-credit contact hour on health literacy. But it talks about the importance for physicians and patients to be communicating and making sure that patients understand what is going on. So improve patient-doctor communication. Make sure that everyone explains how, why, and when to take medication, what should be avoided, how often, would you take it with food or without. Make sure that consumers know to let doctors know all their medications that they're taking. Really improve medication adherence by patients. One of the things that we have done are checklists with people where, you know, the daughter goes in and sets up you take this twice a day, and you have a checklist that they check it off. Make sure that you address those communication barriers such as hearing loss and language issues. Use medication tracking devices. There's much more complicated ones. You can actually use computers. They'll have computers that will, and you're seeing some of these being used in home health, where the computer will say, it's 9 a.m., time to take your medication. The medications come out. If the patient doesn't pick them up, then actually what happens is a phone call goes to the home health agency or to the local daughter in town or something. So you're really using medication tracking devices and ensuring compliance. I mean, it's really wonderful things. It's almost like Big Brother is watching. Some of it's pretty scary. And there needs to be geriatric relevant labeling that address literacy issues, visual issues across the board. Now, risk factors for prescription drug abuse: white, female, lower level of education, separated to divorced, negative life events, and I'm not sure what that means. Psychiatric diagnosis: they're often over-medicated and they develop tolerance and physical dependence. They misread instructions, and then there can be intentional misuse of medication as well. With alcohol, I just want to talk about some myths because these are things that I've actually seen in my clinic, that feeling sad or depressed is a part of growing old and there's nothing you can do about it, that over-the-counter medications and alcohol can be used safely together, that very few women, especially older women, become alcoholics. And this is the one that I actually heard from a family member not that long ago. If an older person says that drinking is his or her last remaining pleasure, it's generally best just allow them to continue to drink. So all of those, once again, are myths, and we need to address them. The big problem, and once again remember that we are seeing in this current older adult generation that we're taking care of now, alcohol is the drug of use. Unfortunately, it is not recognized easily because you don't have an adequate history. Alcohol-related problems are often mistaken for medical problems or even psychiatric problems. Older individuals live alone, so they drink alone, so it's not noticed. I can tell you when I get phone calls with referrals in the clinic, even though we don't do detox or anything, I'll get phone calls because I'm a geriatric professional, and it's after the holidays when the family comes home and they actually find bottles underneath mom's sink. They didn't know she was drinking that much. So they live alone, they drink alone. There's usually no job-related problems and usually no legal problems. And I apologize that you don't have this current slide that I'm going to give you. This actually is from SAMHSA from 2011. The proportion of older adult admissions who reported alcohol as their only substance of abuse literally decreased from 87.6% in 1992 to 58% in 2009. However, the older adults who reported alcohol use in combination with drugs increased from 12.4% to 42% during the same time. So you're talking 92 to 2009. And the proportion of older adults admitted with co-occurring psychiatric problems, so we're having psychiatric co-occurring disorders tripled from 10.5% in 1992 to 31.4% in 2009. While the prevalence of alcohol and substance abuse problems in the general population is under 10%, it's higher for older adults in healthcare settings because people may be hospitalized with a fractured hip due to a fall from drinking. They may be psychiatrically hospitalized for depression when in fact it's related to alcohol. The current rates, and this is from an early 2000 statistic, they looked at inpatient psychiatric units and what percentage had substance abuse or alcohol disorders, and they said it was 20%. And our inpatient geri psych unit at Hershey, we found it was only 10%. So we had this really wonderful, motivated medical student one time, and we had him go back and call individuals who were on the unit. I think it was for a period of 6 months, and pointedly ask the alcohol question. Pointedly ask families if they could, or if not the individual, how much, what do you drink, and it jumped to 20%. So it hit what the national average was. So once again, we aren't asking the questions well the way we need to be. It's always interesting. I find myself in the past few years, after doing so much work with substance abuse in older adults, that when I'm with somebody and doing an assessment on somebody in the clinic, I literally will say, do you drink alcohol at all? And they say no, socially. I'll say, well, when you drink socially, what do you drink? And how often do you drink that? And how many nights a week? So I'm really focusing in on, and then you can get a more of an accurate history, because we hear that social thing and we just sort of blow it off and just write they socially drink and that's it. But we really need, especially as this population increases and the rates we know of substance abuse and alcohol misuse are increasing, we really need to be asking those pointed questions. Okay, the next slide that you have is older adults and alcohol. This is the spectrum of older adult drinking. Currently, there are only 2% that are alcohol dependent. There's 18% that are moderate drinkers. You have 20% at risk, and you have actually 60% abstain. That's the current population. And I'm going to give you the definitions. At risk is drinking more than the recommended limits a day, and I'll show you what the recommended limits are. Problem drinking or abuse is when they have 1 or 2 related problems to drinking. Dependence is when they have 3 or more problems related to drinking, and it's all, and I hope you all know that psychiatry diagnoses through currently by the DSM-4R, the Diagnostic Statistical Manual, the 4th edition revised. The 5th edition will be coming out, I think, in 2013. They're still making revisions to that. But that's how, I mean, there's strict guidelines with diagnoses in psychiatry. Now, types of older adults and alcohol abuse, the types of older adult alcohol abusers. First of all, the at-risk is where there's a pattern of use with the potential for adverse consequences. And these are the people who may have like a drink of wine with dinner, or a martini before dinner, that their quantity and their frequency may not have changed, but because of those age-related changes that we talked about before, that the alcohol is metabolized differently, or they're on medications that can cause some problems. So that is an at-risk individual. The early onset is the individual, and once again, if we go back to that last slide, that's only 2% of this current population. The early onset is the chronic alcoholic. This is an alcohol abuser who's grown in older without treatment. These individuals have a higher incidence of psychiatric comorbidities. So they may have major depression, they may have chronic schizophrenia. There also is a subset of them that do intermittent or periodic drinking. And it's basically the same as the early onset, but they sometimes abstain for a long period of time and don't drink. But then they'll start drinking, and they'll drink for a week or 2. but then they'll abstain again. So that's the intermittent, but the early onset. And once again, remember that the early onset have a higher incidence of psychiatric comorbidity. So there's actually something there. Besides treating the alcoholism, you need to be treating the psychiatric issue as well. So it's a co-occurring disorder. Now, the late onset is where there is an increased consumption of alcohol due to the losses or the stresses associated with age. Represents about a third of older adults with alcohol problems. Part of it's due to the sensitivity and the tolerance in older years. Unfortunately, there's a much more rapid progression of addiction. It's less than 1 year, and you need to remember that this is a significant problem for older women, a very significant problem for older women, late onset alcoholism. Now, the good news is they actually do really well when they get treatment. I had someone come up to me at a conference in Philadelphia a few years ago who said that she had a woman, and it was in a CCRC, a large continuing care retirement community, and her husband had died 3 months before. She was in her own apartment, and the social worker said, I didn't think of, like even checking on her, but she sort of started missing things and not coming down for meals or missing programs or something that she used to see her at. So she stopped in to see her, and she found 23, and I can't believe this, 23 empty bottles of Listerine in the apartment, or some sort of mouthwash that obviously had alcohol in. So the older adult didn't think it was a problem because it wasn't alcohol. So interesting, but she would be considered a late onset alcoholic. So huge issues for older women. Now, when you look at one drink is equal to 1 12-ounce can, regular beer, ale, or wine cooler, 8 or 9 ounces of malt liquor, which is a little bit stronger, 1 5-ounce glass of red or white wine, 1.5-ounce shot glass of hard liquor spirits, and that's 80 proof or less. So if it's 100 proof or more, you really need to even step back and think about that. And that spirits include vodka, whiskey, rum, and other hard liquors. The consensus panel, and this came out in 1998, and it still remains the same. It came out from SAMHSA, which is Substance Abuse Mental Health Services Administration. It's federal mental health, for those of you who don't know. They recommend no more than 1 drink a day for a man, maximum of 2 drinks on any drinking occasion, and for women, I like this, somewhat lower than a man. And the concern, of course, is that alcohol can trigger health problems or make them worse. As I said before, it can increase your risk of high blood pressure and heart disease. It impairs your immune system. Certainly, we know about cirrhosis and other liver diseases. It decreases bone density, and it increases chronic pain, causes internal bleeding and ulcers. Of course, the mental health issues are rampant, the depression, the anxiety, amnesia, cancers of the stomach, larynx, pancreas, liver, esophagus. It really hits on nutritional disorders. Believe it or not, it interferes with sleep, just like benzodiazepines. When you drink, you have a thing called rebound. So you sleep for a while, and you rebound, and you can't get back to sleep. And overall, there's an increase in mortality. Now, I just wanted to talk about risk factors for that late onset, which once again, if we go back to the other slide, the late onset is a significant problem for women. So what you're looking for, or where your flag should go up, is a death of a spouse, friends, family members, relocation. It may not be the older adult relocating. It may be the family's relocated because of jobs. So the older adult is left alone in the home community and just does not have the connections that they had to before. A loss of job, related income, social status. Look at men that start drinking, self-esteem as a result of retirement. Loss of mobility, if they're unable to use public transportation or if they're no longer able to drive due to visual problems or things like that. Impaired vision, hearing, insomnia, memory problems. Look for a family history of addiction. It's amazing that people can share that with you. The gentleman that we saw last week, his father drank, which is one of the reasons the daughter really was concerned about it. So really be aware of those, that history of addiction, that genetic risk. Look at history of depression and anxiety, because people medicate with alcohol. They medicate their depression with alcohol. They medicate anxiety, panic disorders, and things like that with alcohol. When people have declining health, they may use alcohol to medicate themselves. Loss of social support, loss of interesting activities. Of course, protective factors. I always love this slide. I always laugh when it comes up. Access to resources such as housing and health care. I always think that's interesting that we consider those resources, that people have those and those supports. And we hope that everybody does. But we need to really be making sure that people are protected and are safe. The availability of social networks, social bonds. We've known in geriatrics for a very long time the research that comes out with quality of life and quality of health has to do with social networks and support. It's number one in keeping people happy, healthy, and alive. So once again, there's involvement in community activities, supportive family relationships, education, wise use of medications and skills, health literacy, a sense of purpose and identity. And when you talk to anybody in geriatrics, we talk about having people, volunteer, stay active in your church. Really continue with a sense of purpose and a sense of worth. Co-occurring disorders, because physical, cognitive, and behavioral orders are more likely to be present in older adults, and the mental health disorders that you see sometimes with substance abuse or alcohol disorders. Social phobias, people will drink when they go out to socialize because they're uncomfortable socially. Individuals with generalized anxiety disorders, agoraphobia, simple phobias, PTSD, and we've seen this from individuals coming back from Iraq and Afghanistan. The rates of abuse and addiction and alcohol abuse are high. And once again, that can be with older adults as well. Panic disorders, major depression, individuals with schizophrenia will drink so that the voices go away. And I can't tell you how many clients in the 30 years I've worked in mental health that I've seen that happen. In summary, substance use disorders are a serious problem. They are underestimated, underidentified, underdiagnosed, and undertreated. And I want you to think about if individuals were found and we were doing a better job with identifying those individuals and getting them treatment, what that would do to healthcare costs. I mean, and once again, that is health literacy issues. Older adults often have comorbid disorders, and they're at risk for physical and other behavioral health problems. They're at risk for getting depressed. Okay? They're at risk of having more cardiac problems. Prescribed medications and over-the-counters are a major factor in most cases of misuse, abuse, and dependency. However, once again, for this generation of older adults, alcohol is the primary drug of choice. So what can you do about this? What can we do as providers and clinicians? First of all, we need to increase capability for screening and assessment. I'm going to talk about all of these as well. We need to develop age-appropriate interventions and treatment approaches for the current older adults. Okay? For this current, and I'm talking individuals in their 70s and 80s, not the boomer generation. We need to look for approaches that integrate physical health care, meaning primary care, as well as specialty care with screening. And then certainly we need to plan for the increase in the need for interventions and treatment protocols with us baby boomers, because it's going to change. The need is going to change. We're much better educated. We're much more willing to talk about these issues than the generation that we're currently taking care of. We need to really see this as an opportunity to start looking at prevention and early intervention. We need to educate physicians and other medical personnel about these issues. We need to target, the teachable moments, healthcare, behavioral healthcare workers. I'm doing a program at a personal care home this week. They have an individual who has chronic schizophrenia, who is causing some behavior problems, who is older, and they're really struggling. And the case management, the behavioral health care worker, wants to come and hear the talk too, because she's never dealt with an older adult. So really try and encourage some cross-system training. Aging professionals don't necessarily know what to look for as well, even though they work in aging. Substance abuse and aging is a relatively new topic. We need to talk to consumers, family members, and advocates. We need to use natural settings to outreach. And I'll talk about some of the creative things that have been done across the country, but things like senior centers. I do some private consulting with a local mental health county mental health system here, and one of the things that I did one year was focused on depression, and then the next year I focused on substance abuse. And I had, believe it or not, even though depression was not one of their favorite topics, I had much more people willing to talk about depression than there were their substance abuse issues. But I really coined it in the way to use medication and what the responsibility they have with their medications, and making sure each of their physician knows what they're talking. So really, I was doing it basically in a health literacy venue, trying to get them to talk about it. We also need to normalize the message. Stigma issues for mental health, stigma issues for behavioral health. People don't want to be known as the alcoholic. We need to discuss it in terms of a disease that's treatable. And this is what you do to get things treated. You need to be educated so that you don't get into problems with these medications to start with. We need to really talk about, again and again, of integrated approaches. And I'll talk about some of those things, but some of them can simply be doing drug and alcohol screening in primary care and having a social worker there that they can do follow-up if the person comes up positive, that you can have social worker or some people doing counseling in the primary care site, and we'll talk about some of that. We need to screen for risky behavior in all settings, whether it be in high-rise, senior high-rises, whether it be in senior centers, whether it be, once again, in primary care, at health fairs. We've done things like that, trying to really target older adults and screen for risky behavior and educate in the process. So you're educating them about the risk, but you're also screening at the same time. We need to locally advocate for screening programs for all older adults, as I said, health fairs, senior housing, across the board, and we can suggest that, or we can help plan that. We had several county initiatives in Dauphin County, which is in the central part of Pennsylvania, where the capital is, where we actually did health fairs across the county and targeted specific topics using the Area Agency on Aging to set up the programs. And we worked together as a planning team. So we really had some cross-system collaboration, which was absolutely wonderful. I'll talk a little bit more about that in a little bit. I want to just talk about some screening processes, because screening and assessments can be difficult for this population. It needs, for older individuals, not that it doesn't need to be holistic for anyone, but for older individuals, it really needs to be holistic because of the co-occurring physical, behavioral, and cognitive impairments. So there really needs to be cross-collaboration between all of the systems. They all need to be at the table. They all need to be communicating. And everybody needs to know where everybody is at on the same page. When to screen? Routine medical exams. If it's never been done before, it's recommended at age 60. During transitions like menopause, retirement. One of the things I have done in my past is I actually did some retirement training, how to retire and how to make that transition, and cautioning that substance abuse is a risk with retirement because you get bored and things like that. Empty nest. Caretaking, more and more boomers right now are caretaking for older individuals. And just so you know, that caregivers have a significant risk for major depression, and many times individuals will drink as a means of treating it. or taking care of a young child as well. Major life events, including minor traffic accidents, loss in housing, decrease in activities of daily living or driving ability, inability to complete chores, just sometimes the frailty that may accompany aging because of chronic illness may actually cause people to slip into a depression, and they may self-medicate because of that. Who to screen, signs and symptoms. Individuals making excuses, hiding or denying, getting annoyed when you're asked about drinking. Look for people who are falling, and if they're having blackouts or seizures. Bruises are another one. If there may be incontinence, either bowel or bladder, maybe even difficulty urinating or retention. There may be some signs of malnutrition, muscle wasting. They may not have an appetite, and a lot of times that has to do with drinking. Memory problems, being confused or disoriented, slurred speech, visual problems. Individuals who are drinking despite medical warnings, they may have arrest for drinking and driving or frequent car accidents more so. You may see dings on fenders and bumps and things like that. I mentioned before, unexplained bruising, falls, lack of coordination. They may have an increased tolerance to alcohol. Morning drinking, of course, we all know that's one of the major signs. If there's neglect of their home, of their pets, of their bills, of their personal hygiene. If they're irritable, if they seem depressed, preoccupied, if they're having problems. And one of the things that we noticed last week with the gentleman that we saw is there were problems with the family was distanced. The family tried to do what they could do, but they were distanced because he was a little bit irritable, he was a little bit explosive, and we're trying to wean it out of whether or not it's related to his alcohol consumption, which he denies that he's drinking that much, or whether or not it's related to his cognitive issues. And he's having some mild cognitive changes, but nothing major for somebody 86 or 87. So withdrawal from social activities, sleep problems, unusual malaise, suicidal thoughts or suicide attempts even. And just so you know, older white men over 85, do have the highest suicide rate in this country. And it's usually, when they do it, there's usually alcohol involved. So they actually use the alcohol to furtherance. So that suicide is there. And if you're dealing with an older adult population with older white men, you really have to be aware of that. Unusual restlessness, agitation, or aggression, nausea, vomiting. We talked about some of the indigestion things. Now, screening tools. And I don't know, I don't think I put these in the back of your, for resources for you, but you can literally Google these and you can get these tests, and they're all fine to use. They are not, except for the ARPs, we'll talk a little bit about that, but they aren't copyrighted. So the Audit actually stands for the Alcohol Use Identification Test, and we're going to talk about each one of these, the CAGE, the MAST-G, and the ARPs. The Audit actually is a 10-question interview or self-administered questionnaire, and it's most often used in SBIRT efforts, and I'm going to talk about SBIRT and a special program they've done in Florida. It's designed for use in medical settings or wherever the person comes. It screens for risky behavior related to alcohol use. CAGE is the one that I've used the most, and probably most of you have used the most. It consists of 4 questions, and there's 1 point each. A score of 2 suggests the diagnosis of alcoholism. Hinkle in 2001, actually, and you'll see I have the CAGE aid here as well. I gave you some drug, added questions and modified it for illicit drug use. The only problem is, for older adults, studies are saying that you need to supplement amount and frequencies. And even then, you'll see, well, we'll go on. Let me go on. MAST-G, Michigan Alcohol Screening Test Geriatric version. It's well known, 24 questions, yes, no, self-administered. A score of 5 or more indicates an alcohol problem. The ARPs And you'll be hearing about this because this actually is a wonderful way to go about it for older adults. It's self-administered questionnaire. It's 60 questions, so it's rather lengthy. It lists medical and psychiatric conditions. There's symptoms of disease. There's medication use, physical function, health status, quantity and frequency questions are there, even questions about episodic heavy drinking. And then there's symptoms of alcohol abuse and dependency, drinking after driving. It classifies drinking as non-hazardous, meaning that there's no risk for physical or psychological health events. Hazardous, which simply means there's consumption with above risks. And there's harmful, which results in adverse effects. The interesting thing, the majority of individuals who had hazardous or harmful drinking on the ARPS did not screen positive on the Ph.D. Audit or the MAST. And it's simply because the drinkers had medical conditions or used medications that placed them at higher risk. Okay? So that's one of the things that you really need to be thinking about. The ARPS, the Alcohol-Related Problem Survey, they actually use this learning model. So it's computerized, you fill it out, and then it prints out, and then there's this learning model, attention, relevance, confidence, and satisfaction. And the attention is, did you know 1 to 2 drinks a day may be safe for some people, it may prevent heart disease, but for others it may be dangerous. And then it goes on to say, you say you drink 3 drinks every day, but you've been diagnosed with hypertension, you take Coumadin, you're on 6 other medications, and you felt depressed most of the time in the past 4 weeks. Did you know that actually it may be risky for you to be drinking? Because experts recommend that men 65 and older drink only 1 drink per day, and medicines interact, and you're on Coumadin, and you're taking 6 other medications, so that could really be a problem. The other thing related to your depression is that alcohol can make you feel even more depressed. And then it gives you confidence and satisfaction what you should do. Maybe you should drink non-alcoholic wine or beer, or put orange juice in champagne. Don't drink at lunch. Don't drink alone. Talk to your doctor about ways to reduce the amount of alcohol you drink or reduce your medications. Talk to them about your hypertension and your risk for depression. So it literally, that's what's really nice about it, literally kicks this out and really educates. It also, once again, I talked about normalizing the message. It normalized the message. It didn't condemn. It didn't say you're a horrible person because you drink. It said you have you potentially could have an illness, but you know what? This is a real problem because of these other things you have going on, and these things could be at risk for you. The substance abuse screening tools, the DAST is a 20-question self-test. It does not include alcohol use. The Audit is a drug use disorders identification test. Once again, that's 11-question self-reporting. And then there's the CAGE-AID. There's the simple screening instrument for substance abuse. And this is the CAGE-AID, which simply says if you ever felt you should, once again, cut down on your drinking or drug use, have people annoyed you by criticizing your drinking or drug use, have you ever felt bad or guilty about your drinking or drug use? And, you know, have you ever had a drink or use drug first thing in the morning as an eye-opener to steady your nerves or to get rid of the hangover? And once again, a score of 1 or above accurately detects 91% of alcohol users, 92% of drug users. And a score of 2 or greater is considered clinically significant. So you actually can use that for both substance abuse and for alcohol. Okay, in summary, when outreaching to older adults that you think may have substance use disorders, is you really need to gather information and determine whether or not they're ready for treatment. There needs to be formal instruments administered by trained clinicians, and I can't stress the fact enough that they need a medical workup. Okay? You may want to consider instruments developed for older adults specifically and modify them as necessary. In Pennsylvania, we have a single county authority that deals with substance abuse issues, so you would need to do that in your area. And And just, I got a referral 2 weeks ago. I run a dementia clinic, and I got a referral from a primary care doc who sent the wife to me, and the wife's complaint is, my husband, he has memory problems, we think he has a dementia, and he's drinking. He had stopped drinking in 2003, and he is drinking now again. And I said to her, the very first thing you need to do is go and get a medical workup done. Because you just, and she just called the physician, the primary care doctor, and he just immediately referred him to us. But just simply medically, what's going on with him drinking. And then I said to her, you know, certainly we can see him, but he needs to be seen medically first, and he needs to be detoxed, because we aren't going to be able to do any type of dementia screen on this gentleman until he is without alcohol, because it truly is going to affect his cognition. So it's how complicated it can be. And we'll talk about some of the other issues, because they're not necessarily substance abuse services for older, specifically for older adults. There, I think, is one in Pennsylvania. Florida, of course, has a little bit more, and they have the Handler Center, and there's just a scattering throughout the country. But it's very, very difficult, and I can tell you, when I send somebody in, anybody doing detox really doesn't necessarily feel comfortable taking an older adult because of the medical complications. So once again, you hit another bridge. So we really need to be doing prevention. We need to be talking about this and getting specific treatment put into place. So, and we're going to talk about treatment now, hopefully for the next half hour, because I'd like to give you some time for questions. Specialized treatment for older adults, they need extended detox and medical stabilization. That's what I was leaning towards when I was just talking about. It is totally different because of the complicated medical problems, because of potential cardiac problems, hypertension issues, all of those things. They also need slower transitions between levels of care, whether it be going in, and trust me, sending an older adult into the emergency room is nothing I like to do. I don't think it's necessarily a supportive place for an older adult, because it's so pressured, it's so noisy, it can be totally overwhelming, let alone an older adult who's having substance abuse issues. And think about transferring them to another level of care from there, and then to another level of care. Of course, cognitive issues make it even more worse, because when you move people, they get more confused. So the less you have to transfer or transition, the better off you're going to be. You need to make sure that staff is aware of hearing, speech, and visual impairments across the board. Older people do not necessarily say, I'm having trouble hearing you, hence why my father ended up in the wrong room. So we need to make sure that people understand. It's something like 1/3 of the individuals over 65 have hearing problems. Now, the thing to remember for us who are in the business is what older adults hear is lower tones. So when we're talking to an older adult, we need to deepen our voice, sort of like my voice is going now because I've been talking so long. But we need to actually lower our voice. They don't hear higher pitches. So just a simple thing. And that's a normal age-related change. It's a normal age-related change. As we get older, our bones stiffen up, and the bones in your ear that vibrate, that do hearing, stiffen up as well. So you need to deepen your tone. You need to speak slowly and clearly and enunciate to ensure, and ask people, did you understand what I said? Can you repeat what I said? Do you understand the need to get off this medication? Things like that. Address visual impairments. Recognize that older people will need longer rest periods, relaxation, and recreation periods. They may have nutrition issues, especially those who have been alcoholic. Malnutrition can be a big problem. Some people even get B12 injections. Chronic pain can be an issue. Look at issues of grief and loss. People may need therapy because they're dealing with a loss of a spouse. They may need some assistance with developing recreation type of activities if they've recently retired. Look at social supports in the community, look at potential loneliness issues. Current older adults, the good news about older adults is that they are more compliant with treatment and have better treatment outcomes, better than younger individuals, especially those late onset women drinkers. We baby boomers, as I said initially, are going to need to adapt. We're going to need different types of programs. Currently in Pennsylvania, as I said before, there are few rehab units specializing in older adults and addictions. Hanley in Florida, and we'll talk a little bit about that for older adults. I do want to mention that this just happened the end of last year, that Medicare will help pay for the treatment of alcoholism and drug abuse for both inpatient and outpatient settings, and that is new. If they receive services from a Medicare participating provider or a facility, and if the doctor states the services are medically necessary, and if the doctor sets up your treatment plan. So there is Medicare reimbursement. Before it was spotty. Now we know there is Medicare reimbursement. I can't speak to how that is working. I'm hoping now that that's there that we will have more substance abuse institutions developed that will work with specifically with older adults now that we have Medicare reimbursement. It sounds like an easy Medicare reimbursement as compared to being piecemeal before. I do want to talk about SBIRT, which stands for Screening, Brief Intervention, and Referral for Treatment. IRETA actually does training on SBIRT. It's a wonderful program. It's really health and wellness focused. It is formal and brief. It's actually used for prevention, identifying risky behaviors, as well as screening for more serious problems. You can use it, and that's why this is so nice for older adults, because you can use it in natural settings like primary care. You can use it in senior centers. You can use it in senior high-rises, health fairs, and it really normalizes the message. SBIRT stands for Screening to Identify Those at Risk, Brief Advice, where there's one-time interventions for short consults and information or literature. There's brief interventions where there's one or more short motivational sessions to encourage and promote healthy behaviors. There's brief treatment where there's 1 to 6 interventions, and it can be motivational enhancement therapy, cognitive behavioral therapy, provided by trained interventionists and counselors. And there is a referral to treatment for dependent users who really need more specialized services and case management. The brief advice and brief intervention is confidential, it's non-threatening, non-judgmental. You preface the question with a link to a medical condition that can make it more palatable. I'm wondering if your alcohol may be the reason your diabetes isn't responding or your hypertension isn't stabilizing. And the thing to remember, the key components of brief intervention are appreciate the problem, identifying the goals, summarizing the health habits, educating about the standard drink sizes, and once again going back to that SAMHSA tip, exploring why the person drinks, what triggers it. Is it the loss of a spouse? Is it because their family moved away? And help them find reasons to cut or quit. You want to get your diabetes under control. Develop a drinking agreement and be aware of the risky situations that may trigger drinking, when the kids go back after the holidays type of things. We need to remember to avoid using euphemisms that may minimize the problem. The client may deny. We need to remember that they're going to deny and engage in denial and rationalization. There are those who are inadvertently misusing, and they're unlikely to be defensive about the need for change. We need to, of course, use active listening techniques, confirm the problem and reiterate it. Keep reiterating the problems. Characterize the dimension. Develop an individualized service plan that the individual takes part in, so you have the buy-in for that. And certainly, especially for older adults, refer for medical workup, and for everyone, medical and psychiatric assessments as needed. I just want to mention the Florida Bright Project, which actually just ended last September, and I don't know if anybody else knows about this, but I actually have the link at the back. So I just want to talk briefly about that. Florida Bright, and it was done in Florida. It stands for Brief Intervention and Treatment for Elders. It actually was funded by SAMHSA, the Center for Substance Abuse Treatment, in 2006. It was a $14 million, I think, a 5-year grant. And what they were doing, actually it was a 3-year pilot project. It was focusing on providing services within primary and emergency health care settings, public care settings, CCRCs, nursing homes, assisted living, at the sites coordinated by aging services like senior centers. Some sites are continuing this, and as I said, it ended in September, but they were offered SBIRT. They had screening, brief intervention, brief treatment by generalist providers, or they were referred out depending on the need. They were in retirement communities, trauma hospitals, primary care, urgent care clinics, and I'm reading this off their little blurb. Since it began, there were 31 Florida Bright provider agencies in 18 counties conducting screenings in more than 70 different locations. And this is the wonderful thing. By the end of the grant in 2011, over 91,000 individuals were screened. And most, 93% of those were 55 and older. So just to show, Florida obviously took the bull by the horn and really took off with this and proved that it can work. So I think it's one of the things that we need to be talking about as this population ages and as we're seeing increasing problems with substance abuse issues. Another intervention, and I want you, as I read this, the first time I read this article several years ago about this program, I was thinking, how can this be? This one's called Project Goal, which is Guiding Older Adult Lifestyles. Now, of course, I'm a skeptical person, and when I heard this, I thought, I just can't get my handle on how this works. This is actually 2 10 to 15 minute physician-delivered counseling sessions scheduled 1 month apart. Now, I can tell you the average time that a primary care doc spends with you is 7 minutes. It may be 6 right now. I think it actually dropped. So this is a specific thing. I believe it was done in Wisconsin. And what they did advice, they did education, they actually contracted using a scripted workbook, and then they had follow-up phone calls by a nurse 2 weeks after each session. So they had this set up, it was primary care based. Now, this is the thing that blows my mind. The older adults receiving the brief physician-delivered intervention showed 34% reduction in 7-day alcohol use. 74%, you can look at these numbers and just go, oh my gosh, 74% reduction in the mean numbers of binge drinking episodes. And then you have a 62% reduction in the percentage of older adults drinking more than 21 drinks per week compared with a control group. So as I read this article, I'm sitting there thinking, how can this be? Just how can this be? And then it hit me that it was actually done a few years ago. So this was this older adult population. So my question to myself then, would this type of program work with a baby boomer? And how would we see the same type of reduction in alcohol use with baby boomers with this type of program? So I think that's one of the things we need to start talking about, is where we go from here and what type of interventions we need to be developing for baby boomers. those, because it's going to be a whole different ball of wax in dealing with us. So just something to consider. That's one reason I left this slide, and I think it's a really wonderful, wonderful slide. Now, just in prevention, and I can tell you I'm probably going to finish a few minutes early. Prevention, we have a wonderful program in Bucks County in Pennsylvania, which is outside of Philadelphia. It's called Project Meds. It's medication education designed for seniors. And you know what? I put these things here so people can talk about it and maybe develop similar programs in their county. This is actually senior volunteer peers that deliver these education programs. And I've seen them do it, and they're absolutely wonderful. And they will go anywhere. So using seniors to educate seniors, that older adult peer type of thing. The Elder Health Program, which is in Baltimore, this is consumer drug education for older adults and their caregivers. It's by the School of Pharmacy at the University of Maryland. Senior Helping Hands is out of Minnesota. It's an outreach program that addresses the older adults, needs of older adults with substance abuse disorders and mental illness. Senior Sense Speaks is a wellness program that trains seniors in the safe medication practices. I'm sort of getting tired, and warns them of alcohol abuse. I know there was somebody registered on the call from Rochester, and if I'm remembering correctly, Rochester had a wonderful outreach program for older adults with substance abuse disorders as well. And for the life of me, I've been trying, since I saw that list, I've been trying to remember the name, and I can't, so I apologize. But I think there are some wonderful programs across the country. I think it would be wonderful that we started building some sort of database talking about services for older adults with substance abuse disorders. I think that's something we need to start doing and sharing some information. I'm big into Google Groups and sharing information. So because I think this is going to be rapidly become, I think it's getting, as I said in the very beginning, this problem is growing faster than they originally thought. I can tell you in 2005, when I was looking for funding, I was the executive director of the Pennsylvania Behavioral Health and Aging Coalition. I was sort of setting it up as a nonprofit, and I was looking for funding, and the only funding out there was on substance abuse and alcohol abuse for older adults. So I think the federal government has seen this coming for a while, and I think now is the time that we really need to start talking and sharing with each other about what we can do and how to help our communities as we start struggling with this. What we can do, actually the handout that you have will say what we can do, period. And I'm going to talk a little broader than what we can do in Pennsylvania. First of all, we need to increase the education and awareness efforts in the general population and professionals. I am big on using pharmaceutical companies to educate. What I'll say, and I always laugh, is they're the only people anymore with money. And I just think they are the people to put stuff on during Wheel of Fortune and Jeopardy and Fox News to target older adults that this could be a problem and you shouldn't be doing this because it can affect. What a great way to educate and get the word out there, because some of this generation of older individuals do not have access to computers. I mean, like I said, it's going to be different for us boomers, but this generation really is much more TV-based. So finding funding, finding a way to get some things based nationally on TV could be an issue. We need to use approaches in prevention, intervention, and treatment that involve, I love this term, natural systems pathways. We need to integrate it. Primary care and health care. There was a wonderful TV show on PBS, a documentary on healthcare where it's actually working in this country. And it talks about how things are embedded in primary care. Mental health care, behavioral health care needs to be integrated. It all needs to be integrated, especially for older adults. We need to come up with ways to finance and incentivize development of models of prevention, education, and treatment for older adults. We need to include older adults recovering from substance abuse disorders in planning efforts. We need to ensure routine screening for older adults where they frequent, whether it be a senior center, whether it be in a high-rise. We did depression screening in the high-rise. We did, and to get them there, we actually said it was Blues Day. So they had a blues band play. They served wings and blue cheese, they had blue corn chips, and they did depression screening. So really sort of non-threatening type of approaches to outreach to older adults. We need to build a workforce, next slide. We need to build a workforce capacity to deal specifically with these older adult populations. 1% of all nurses are specifically trained in geriatrics. It's even lower in primary care. It's, I think, 4% in social workers. So we really need to be focusing our workforce capacity to deal with professionals and paraprofessionals on the needs of older adult populations. We need to create opportunities to bring evidence-based approaches and promising practices to the front line, forums, e-learning, and incentives across the board. We need, I'm skipping around here, we need to remember that reducing and treating substance abuse problems among older adults will require, and this is the big stress, I want to stress this with you, it's the big thing to remember is this integrated system of care that combines medical and behavioral services, and this actually comes from the illicit drug use among older adults from 2009. They required an integrated system of care that combines medical and behavioral services to fully address the spectrum of problems that older adults bring to their primary care setting. Extremely important. Once again, integrated system of care where there's communication across all bounds. Now the resources that I have listed for you here, SAMHSA put this out in 2003. It's Get Connected. I think I'm actually listed in there at Hershey Medical Center at Penn State. Some of the stuff, there's certainly been a lot of stuff that has been updated since there, but they have some really wonderful ideas on how to link older adults with alcohol and medication disputes. So that's a wonderful resource and it's free. The Technical Assistance Older American Substance Abuse and Mental Health TAC is listed there as well. The National Institute of Alcohol Abuse and Alcoholism. Loretta, of course, who is putting on this webinar today, the Institute for Research, Education, and Training in Addictions. And you can find information, and I believe they train on SBIRT. The Administration on Aging also has some substance abuse in older adults. The American Society on Aging offers web-based training as well. Brown University has distance learning program that I took in 2008. It was a 10-credit course. It was 6 weeks during the summer. Online learning, it was absolutely wonderful on substance abuse in older adults, and there's the link for that there. It costs $45, believe it or not. Back then it's probably a little more expensive. I have a link there to the Hanley Center in Florida, which is like the star of older adult substance abuse treatment in the country. And then the Florida Bright, I have a list there to that as well. And that is the end of my PowerPoint, and I guess we're going to open it up for questions.
Yes, we will. I will turn the slide back over to me now so that it will just show that the title slide.
Okay.
Okay. Now, yes, I do have a few questions here and comments that people have made during the session. The first one says, I would be careful with the term accidental addict as it has a negative connotation. Some differentiate between addiction and medical dependence, which occurs from taking medications as prescribed and developing a dependence on them. These patients usually do not exhibit the behaviors that others with addiction exhibit, such as be dishonest, losing prescriptions, getting scripts from multiple doctors, using more than prescribed, manipulating caregivers, etc.
Yeah. Yeah.
So they just wanted to have that differentiation noted.
Yeah. And thank you for that.
Another asked about the screening tools. This was before you gave all the links and told everybody where they were available. But she wants to know, how do you handle the results? Do you notify doctors or refer to local resources?
Well, I think you do both, and depending on what the client, once again, I can't stress enough that there needs to be, physicians need to know if people are actively drinking and how much. So I think there needs to be conversations with everybody involved. And of course, one of the things that I do is I have individuals sign releases for everybody, just so we can make those connections. And I discuss the importance of that and why.
Okay, and then there are a few comments from one of the attendees here. It said, in methadone treatment, we see older patients overdoing benzodiazepines, cocaine, and alcohol. They refuse to deal with the problem, arguing needing all the medications and the drugs to feel better. How to deal with illegal and legal drug abusers is a challenge every day in methadone maintenance treatment. I consider that medical health care professionals and chemical dependent counselors need to work together for the well-being of the patient.
Yes, excellent. I can't imagine trying to balance that. And I think that once again speaks to that cross-system collaboration that needs to be there with everyone, but I think specifically with older adults because there's so many different systems involved. But yes, thank you for that. Excellent.
And the same person says, older adults used to feel offended when their drug use and overdue medication is addressed. Other problem is the family members expect miracles from the chemical dependence counselors, and they like to challenge them.
Yes. I agree. And I think that one of the things we need to remember is to be realistic. And just thinking, looking at these questions, and look how many different types of abuse that we're seeing across the board. I mean, it just even in this discussion, and the different skills that are needed and different resources that are needed.
One person asked, when are B12 shots called for?
You know what? I have seen, and I had somebody come in who is getting them who isn't even have a history of substance abuse. So I've seen things in literature that says it's worthless. And once again, I'm seeing it again. So I'm not, that's a medical question from a primary to a primary care doc. And you know what? I think it's going to vary depending on the PCP. Because as I said, I heard that for years I heard it's worthless, it doesn't work. And I'm starting to see people come in getting injections again monthly. So, but specifically for substance abuse, I think that's part of it. But that's a medical doctor's, that's their decision.
And I hope I pronounced this correctly. Somebody's asking you to define hyperalgesia again.
It's actually, I love that word because I can really hardly say it. It's an increased sensitivity to pain. And they're not sure what causes it, but it's due to long-term opioid abuse. And they think there's actual damage done to pain receptors. But it's an increased pain sensitivity. So it's like people are hypersensitive. And so the balance with that is treatment, but it needs to be addressed.
Okay. That looks like it's the end of the questions that have come in so far. So if anybody else has anything, please get it in now, and we will address it before we adjourn the webinar. And I want to thank you, too, for advertising IRETA in the Northeast ATTC. If I'll put it in the follow-up email too, but I'll put in the link to the expert site we have where they can get a lot of information, and some of the screens are listed there too.
And you also train on that too, don't you, Chris?
Yes.
I thought you did.
And there might actually be a couple of our recorded webinars that we've done on expert that are on our website. So I'll put that on too if somebody wants to watch one of our previously recorded webinars. I don't see any more coming in at this time, so I would say we could safely close this out, and everybody just look for an email from me, and I hope you will all join us again soon. Thank you, Linda, very much. It was a really interesting webinar.
Thank you.
Okay, bye, everybody.